Well, good afternoon, everyone. I'm Scott Malaney here from the international studios of the Blanchard Valley Health System in Findlay, Ohio. With me is my colleague, Dr. Bill Kose. We appreciate you taking some time being with us today. Really a couple goals, and they're very straightforward. One is Dr. Kose is going to provide some information, the latest. We have the ability to be tracking this dreaded disease around the world, and he's going to bring us up to date a little bit about that. And then we're going to answer some questions. We've had a number of questions posed to us over the last couple days, and we want to try and get as much information out as we can. So that's our goal. We look forward to the time with you. And again, thanks for being with us. And I'm going to turn it over to Dr. Kose.
Thanks, Scott. Maybe just to give a little bit of thanks to start with to the community. One of the things that we've been really impressed with here at the health center is all of the positive comments that have been made, the lights on, the porch lights, et cetera, especially for our frontline staff. I've been really impressed about how the community has come together. So starting last evening, I was talking to my mother, who's 96 years old and assisted living, and she's not been able to talk to anybody really from the family for the last 2 weeks. And I'm sure a lot of you are in the same sorts of communicating with what this COVID virus has done. So I told Mom that I was going to be on Facebook tonight, and she wasn't sure what Facebook was, but she did say, well, maybe you could answer this question. As smart as you doctors think you are, how did we get in this mess that we're in? And I think that's a pretty good question. When you talk about the virus of what happened, for anyone to have an infection, you need something that's causing the infection, and you need someone that's the recipient or is the person that gets sick. So I thought maybe it would help a little bit at a high level to talk about something now that's infected over 1 million people, that we've had deaths of in the world that are in the thousands. We're seeing that we have had in the United States, obviously more and more. And as we talk about the surge, what does that really mean? Well, a virus is just a small particle that attacks cells. We think this virus probably came from bats, maybe related to some animals that are being sold in marketplaces, and it jumped over from the bats to humans, and this is the cause of what's happening. The virus seems to have an incubation period of around 5 days, may last up to 14 days. One of the things we're getting more concerned about is maybe up to 25% of people are asymptomatic carriers, meaning that individuals that you don't think have the infection, whether you're a doctor examining them or anyone out in the community, that they may be a carrier. And that goes then from the virus with the person that's being infected to the point that we have some fatalities. That virus is small, and we'll talk a little bit later about what you can do to protect yourself with masks and things like this. But basically, the idea behind the surge, and what's really important to understand in this disease that's different than the flu and other things, is we have no immunity. There's no individuals that we're aware of that have ever been exposed to this coronavirus. And so that makes us all susceptible. And that's different than in general any other kind of an infection. I used influenza, and it's been compared to that. But most people have had at least a little bit of immunity just by exposure. In addition, everyone up to 90%, 95% of individuals get a flu shot, so that they have some vaccine or immunity that goes along with having been exposed or again having the flu shot. In this case, no one has immunity, and so the virus can expand exponentially. And what's that mean? Well, somebody sent me something that I thought really explained it fairly well. If you took a lily pond and you said you had one lily and the lilies doubled every day, how many would you have at the end of 30 days? Well, you'd have about 1 billion if everyone in the doubling process of what occurs. Well, we've got about 8 billion people that live in the world. And so you can see how fast that is. And what happens when you ask the question, then how long did it take the lily pond to be half full? Well, that was at 59 days, or in this case, I'm sorry, in 29 days, it doubled and filled up the pool. So what we've tried to do, and the really important points about how we try to treat this disease, are the things that have been talked about from day one. Go back 6-8 weeks ago. Social distancing. The virus is spread by droplets in general. And so if you are socially apart, you're not going to get anything through those droplets of someone coughing or sneezing. Also, we've had individuals, if you're trying to take this pond and reduce its size, by quarantining themselves. If you have been sick or you've been exposed, if you stay home, the virus can't go anywhere because it's not touching someone else or your exposure. The same idea in the model that was developed about how we were going to prevent this, that worked with other epidemics and pandemics that we've had. We're closing schools, closing universities. So again, you took part of where that population that could be expanding and tried to isolate themselves so those things didn't occur. And we have worked really hard about doing that. And I think we've worked really hard in this community. I've seen the community try to do this. One of my friends last night was walking outside. They were 6 feet apart. They were talking to each other and they pointed to me, "Doc, we're 6 feet apart, just like what we're supposed to." And I've seen that. Obviously, we're not seeing as many people on the roads, but all of those things are important of stopping the surge, which means that exponential increase we will be able to stop. And hopefully that's going to slow down the curve. We've all heard that. So it doesn't go up as fast. And so we smooth it out. So we'll have enough healthcare workers, ventilators, ICU beds to be able to take care of the population. So I'll turn it back to you, Scott. That's kind of my high level. Is there anything else you think?
Well, one thing I've learned about this, and I'm a layperson here, but the way you get the virus into your body is through your mouth, your nose, and your eyes. And it's actually fairly hard if you're around someone that has the virus and they're sneezing and coughing and you're breathing that air for 10 or 15 minutes. That's a way you can get it. But it's pretty tough, from what I've been able to understand, to just someone sneezes once and you're near them. It's pretty unlikely you're going to get the virus. It happens from those 3 orifices. So trying to keep your hands out of your mouth, nose, and eyes is the challenge. And for someone like me that's just absolutely horrible at that, I can tell you there's probably an over-under bet going on right now as to how many times I'm going to touch my face during this time. I'm going to tell you right now the answer is 0, but we'll see. It really helps. So we have some questions here. Billy, you ready to deal with some questions?
Go ahead.
Okay. Larry from Findlay is asking, how many of our Findlay, Hancock County residents have been tested for COVID-19? And what are your plans to continue testing? So maybe that's when you could take that.
Okay. Well, we started a triage center and we have what's called Tenseti. We have fielded really over 1,600 calls as of this afternoon. And we've tested somewhere around in the Blanchard Valley system through Tenseti, a few in the hospital of around 170. One of the things that, and we get lots of questions about this, individuals would like to be tested for lots of different reasons, to be able to go back to work, to know whether they have it, et cetera. I think most people have heard we are very limited to the number of tests that are available to us. That has changed how we treat people, what we're able to do, the triaging, because we just don't have the capabilities of doing a lot of testing. But we've done what we can. We have 2 laboratories where we send these out to. We're in the process of evaluating, is this something that we might be able to do internally as technology becomes a little more available.
And so far, I think we've had around 12 positives.
I think we've had 12. Not all of those are in the county. I think the last that I saw in Hancock County was 9. And so we do know that that's out there. And the point also is how many others would be out there that are asymptomatic? And that's the problem. We just really don't know. What we do know is it is in the community.
Yeah, that's a good point. Another thing that's an oddity about this, there are countless reports of people finding out they have the virus and they have no symptoms at all. And to the point Bill made when we started, that makes it really tough. Someone is they call it a shedder. The virus is out around them and they don't even know they're sick. Pretty unusual, I think. So anyway, next question comes from Jane in Findlay. And by the way, Jane, thank you for sending in your question. Does the total number of cases reported for Hancock County, or really any county, change when patients recover from COVID-19?
No, really what we do is we keep track of the number of individuals that are positive. And so once you're positive, you're one of those now that has some immunity. We think, and one of the answers that I have had to probably more than any to questions that I've had is, I just don't know. We don't know that much about this disease, but the apparent from what we've learned from China is that you're not going to get this again, at least in the time period of 2 or 3 months of what occurs. So you develop the antibody. We don't track and say you're cured. We don't subtract that. We just say this is the number of positive cases we've had.
Thank you. Nancy from Bluffton asks, what process is BVHS, Blanchard Valley Health System, using for testing? How soon do patients get results? And I'm going to turn it over to Bill, but this has been a big question for everyone all over the world regionally, actually. So go ahead, Bill. This is an interesting problem.
It's been really difficult because, and this is part of that is what Americans expect. We're used to instant gratification that we're going to get a test and we're going to get it back and we're going to know what's going on. One I've already talked about, we don't have the capabilities of doing the testing. When we first started, we had to send it to the Ohio Department of Health. We were waiting 4 or 5 days to get results back. We switched to some commercial labs. Some of those we still don't have back. But in general, now if we swab and send in through the protocol, we send in the test, we are getting back results within 36 to 48 hours, which really has helped us in the hospitalized patients, the PUIs, the possible infected individuals, that we're able to let them go home or to move them out of isolation. So it's really made a big difference with us being able to get the test back quicker.
Just for acronym purposes, PUI is person or patient under investigation. So those are people that we sort of assume might have it, but the test results aren't back yet. That kind of individual. So I think we kind of talked about the next one, but Kathy from Van Buren asks us, if you contact COVID-19 and successfully treat it, can you contract it again, or are you immune?
No, we as I said, we do think you're immune. Now, the question is, how long can you be contagious and we know you have the disease? We think, and what we've advised people that are going home or even been in contact and have had something and haven't had a test, is that 3 days after you haven't had any fever and really not having much as far as symptomatology, you are probably not going to be contagious. And I think that's pretty much what you see with other viral illnesses, that's a good way to look at it.
Thank you. Danny from Findlay is asking, is an immunity test being developed so those who may have already had COVID-19 can be ruled out as potential future positives? Would this data not help to flatten the curve also?
Well, I think it would. And there's two parts to that. As far as the question was an immunity test. So if by what that means is, can we tell whether you've had it or not? Yes, that would be something that would be beneficial. And I think the way the question was asked, that we could rule you out. So if you are completely asymptomatic and had a positive test, let's say in a couple of weeks, yes, we would be able to say you are immune to this disease. That means you could be in contact with other individuals. We are going to struggle. Well, I don't know if the word struggle, but we're going to have to figure that out about healthcare workers, because we're going to get this despite all the precautions that are being taken with protective devices and masks and all those things. And when can they go back to work? our assumption is going to be if you turn positive and your symptoms have gone away, you're immune, your test would show that, and you're okay to return to normal society.
One of the complexities here, and Bill, I assume you've read this too. Recently in China, they've had some patients who've had the disease, recovered, actually tested negative for a period of time, pop back up with it again. Is that they recaught the disease? Is that it never completely left their system? We just don't know yet.
Yeah, and one of the things, and I don't know if I will explain this real well, is we don't have a gold standard to compare the test to. So I read somewhere today there is more research going on about this than ever has occurred in the history of the world. The number of people across the world that are trying to figure out the research, but we don't have a test to say this is positive for measles, and then we're going to see if we can get a new test to compare to it to know how accurate it is. We think it's pretty good, but there are more, and I think in that scenario, there are more cases coming back. Well, we did the test, but it was a negative test. Well, maybe what happened was you hadn't had it long enough to turn the test positive. You didn't have enough of the virus in you to turn it positive. And I think we'll learn a lot. Somebody's going to write a great book about this in a couple of years.
You thinking about doing that?
No, I'm not smart enough. I can't understand the math. There's
I guarantee you he's smart enough. He just doesn't want to write a book. This next question, it's a good one because I've heard this too. And I think as a physician, this will be a good one for you to talk about. Will ibuprofen worsen COVID-19 symptoms?
Okay, let me answer that with a little longer answer than just about ibuprofen. So what are the treatments? One of the ways that in general, when I went back and I talked about the lily pond, about what you can do to reduce that propagation of the lilies, is one thing you can do is develop a vaccine. And that's what all kinds of research is being done. And that will prevent people from getting it. That would be the flu shot. That's why we all in general get flu shots or vaccines for all kinds of things. The other is to have a disease that you can treat. So if I were to get an unknown disease, but it could be treatable, then I also become immune. I've got the disease, I have the antibodies, and with the treatment, then I can be felt to be not going to be contagious. I'm not going to catch it again. So when you talk about treatment, there are all kinds of things that you can read on the internet and we're talking about. So specifically talking about ibuprofen, from a standpoint of what the anti-inflammatory drugs are, which would be ibuprofen or Aleve or a lot of others, is that theoretically you could say, well, you need your immune system to fight the infection. Therefore, using something like that might be counterproductive. There really isn't good data to say that. Nobody's done any research studies, taken this number of people on ibuprofen and the ones have COVID and not. But that's something that has been talked about, and I would, like I said, say theoretically possible. What we're advising people to do, it's probably a little bit safer to use acetaminophen or Tylenol. So the other thing, I might as well say something about treatment now, is that there's been a lot that's been on the internet about using Plaquenil and Z-Pak, the drugs that you've seen.
Plaquenil is that?
It's an anti-inflammatory. It's used, people that have diseases like rheumatoid arthritis or things have used. I have to say, theoretically, I can't figure the theory, but somebody has used it. And small studies, it looks like it may cut down the viral load. And because this was publicized, there was some hoarding and selling, and it became quite unavailable. We do have some here, and we have treated some people with it, but we're not sure how effective it's really going to be.
Thank you. Next question is from Rashmi from in Finley. And this is one I'm going to take a crack at, which is a little scary, but I'm going to take a crack at it. When will BVHS start allowing elective surgeries again? Well, the quick answer is when the governor lets us. But let me try and explain that a little bit more. Our governor was one of the leaders in the country in realizing this social distancing and other matters, other kind of techniques like that were going to be valuable to us. So what he asked of us all over the state was that we cease and desist, if you will, doing elective procedures. And then he allowed the Ohio Hospital Association to work with a group of hospitals. We participated in what's the definition of elective procedures. And the goals were real simple. One is we want to not use any more PPE or personal protective equipment than we needed to because we worried that the world supply was low. And the second is we wanted to be as safe as possible. So around the state, we had a number of phone calls and decided that most surgeries could be determined to be elective. And yet each hospital is asked to have a little committee internally so where doctors can really appeal to have a case be deemed to be not elective, but actually something that's urgent, needs to be done. Pain management procedures, many cardiology procedures, catheterization procedures that are not urgent, and also interventional radiology procedures. So for Blanchard Valley, that has very significantly reduced the number of procedures that are going on here on any given day. So when will that be allowed to start again? We don't know the answer. I can tell you this, it won't be anytime soon. The governor believes, and I think correctly so, that there's some evidence the social distancing is working. What I do think will happen, and is happening actually, is some cases that were elective as time goes by, symptoms can worsen, conditions can worsen, and a physician may appeal and say, this patient just can't wait any longer. So we are seeing some of that, and we do have the authority to handle those as they come along. So hopefully that's not too long of an answer. Thank you again for your question.
I might just add that, as Scott said, we have a group of surgeons that are looking at that, have been very diligent. And I want to, to the community, that we're still, we've got criteria as we look at it. Scott mentioned that, so if a lady would have a positive appearing something in their breast, we are still doing those kind of things, but we're being as judicious as we can because we don't want to expose the patient. And in addition, we only have so much protective devices. And so it is really a balance. But some of these decisions that have moved cases back are being reviewed at 2 or 3 weeks to see where we are. So I want to reassure the community we're trying to do everything we can. But as Scott said, that was governor's orders, and I applaud the governor. He has done a great job. So none of us would be critical of his decision making.
You know, and for what it's worth, I would kind of applaud hospitals and doctors around the state. We have worked together very effectively. We came up with a plan. The governor accepted it, and with very few exceptions, the compliance has been very high. Let me take a quick second here. Ladies, are we getting anything in at your end that we would want to respond to? Or if not, we'll keep going here. And if you have anything, let us know. How's that?
One of the questions that came through is from Beth. She's asking, why do we not have the capability here in America to test like South Korea in large numbers across their population?
Let me try and repeat that. Beth, thank you for your question. Why can't we test here like South Korea did? Bill, would you want to take a crack at that?
I think, first, it's a really good question. And my understanding is that they looked at this a little bit quicker. They may have been through this before. They don't have as big of a population, but they were able to develop quicker the testing itself. And I honestly don't know why they were able to do that. They also, it's again, a different political system that they followed contacts. They made things mandatory. They checked a lot more people to see what was out in the community. But I really don't know why they had the availability so much quicker than what we were.
I do think one thing about that's embedded in Beth's question is, as we look back on this, around here we talk about things in terms of being an OFI, an opportunity for improvement. As a country, we will recognize the inability to provide as many tests as we would have liked has been a deterrent for our ability to deal with this. So
that's for sure.
Yeah, no doubt about it. Marissa from Finley is asking, what system do you have in place for regular medication maintenance, like a Coumadin clinic? Coumadin, by the way, is a medicine, a blood thinner. Are there, see, I know that stuff. That's pretty good.
I'm impressed.
Are there procedures in place to protect healthy people entering the facility? That's a great question. Thank you.
Well, one of the things that we have learned really on the fly pretty quickly is to how to talk to individuals, and especially using technology, telehealth sort of thing. So we, not only at the Coumadin Clinic that I'll specifically answer, but many of our offices, our specialists, our family doctors are reaching out that way. We're also trying to get an idea of when someone needs to come in to be seen, that we can screen that way to see if we need to be worried about COVID. Do you need to be screened? So specifically, the pharmacists are reaching out to individuals in the Coumadin Clinic. One of the problems with it is that you do need to get a ProTime drawn. That's a blood test to see how thin your blood is. A lot of times you can look back over the history of someone to see where they are, probably don't have to change the medications, but we still are open for routine business. So we still do x-rays, we still do blood draws. There are things that we need to do. What we've tried to look at is, let's say a ProTime may be more important than a cholesterol. That's something that can be put off and looked at later. Likewise with other kinds of blood tests. But that's the way we've approached it. And I know one of the other things that there's been a concern about even coming to the hospital now that we've only have 2 entrances is that a problem? Well, to be honest, I think you're pretty safe here at the hospital. We know the procedures. If you go back to what Scott said, these are droplets. We are cleaning all the time. We are putting masks on anybody that appears to be sick that comes into as a patient. We are limiting our visitors, that we don't have anyone now except for obstetrics. And so I think it's a pretty safe place if you do need to come in.
Thanks, Bill. Barry from Finley, good question, Barry. Can a patient make an appointment with a family physician for a non-emergency, non-COVID-19 visit?
Yes, they can. What you should do is call your primary care provider. So when we started our triage system and when we started the tent city, the overlying problem was we don't have enough PPE or protective devices, masks, etc. So rather than having you go to your primary care doctor and not only have to suit up, it would be a utilization of a precious resource. We decided, along with talking to our primary care physicians in town and our practices, to try to centralize where we're doing that. But for routine kinds of appointments, if you don't have an infection, part of the screen that you certainly can call and talk to your provider, or if you've been screened, you can go back to your provider. We still encourage everyone to be talking to whoever their primary care provider is.
Arthur from Toledo. Arthur, I appreciate your question too. What steps are you taking to be prepared for the virus when the curve goes up, the so-called surge, and beds are scarce? That's a really big question. Go ahead.
Well, we've probably spent the last 3 weeks and increasingly spending most of our day trying to figure out what's going to happen with the surge. First, we don't know when the surge is going to occur. I talked a little bit about that. The surge being that all at once we go from having 15 cases in the community to 150, potentially, depending on the model, that we could get up to several hundred. How are we going to take care of those people? So what we have done is we have looked out to the community and we have talked to the community as well as internally, where we spend most of our time in trying to look at several things. I think what you read about in the newspaper or what you'll see on TV, the media, is about the number of beds and also how many ventilators do you have. And that's understandable. Now, 80% of people that get this disease don't go in the hospital. Most people are able to take care of themselves at home, quarantine themselves, get over this in a couple weeks, and that they do fine. Of the 20% that come in, there's a certain percentage that may need to have a ventilator. And that's what's really important about the social isolation, especially for the elderly like me, and then for individuals that have diabetes, not really high blood pressure, but heart failure, chronic diseases, especially of the lung, like chronic obstructive pulmonary disease or COPD, to try to isolate them. Now, so with that being said, then when we get to the surge, we're hoping that the curve will be flattened, but we have looked at these capabilities. One of the things we've done, we're a 150-bed hospital. We could turn those beds into 2 individuals in a room. So if we have bed capacity, we could have 2 individuals. Now, we wouldn't have one person with COVID and one without, but it would make it no problem at all to be able to do that. That increases our capacity to 300. We've also looked at the different other places in the hospital, because as you look at this, it's not, again, just having a bed and a ventilator. You've got to have staff. And that's probably the biggest concern. It's not the geography. It's not the utensils that we need, except for PPE. It's that we've got to have healthy staff. So you need pharmacy. You need to be able to get your medicines. You need to be able to get oxygen. You need to be able to measure those things. So as we've gone through the surge, all of those criteria are being looked at as to what we can do. And I've been asked several times, and we have had just great community support. Well, we can be of help. We were at the university today. We have a team that's looking at the surgery center today. We've looked at our pain management of other places where we can have individuals go that are positive. And we also have Bluffton Hospital. It's a critical access hospital, but has the capabilities of taking care of individuals. So that's all part of my long-winded surge.
Going back to a basic here, it occurred to me something Bill said might be helpful to some of you. Why is the COVID virus, why are we seeing ventilators? What's the deal with lungs? And I'm going to give you a layman's take on it, but I think it's pretty understandable. This virus, you see the pictures of it. It's a round circle. It's a protein with these spikes on it. Well, the spikes, the way they're formed, are particularly good at getting stuck in lung material. And lung material is particularly warm and moist, which is good for helping things like those reproduce. So people that are heavy smokers, as Bill said, have COPD or other compromised kind of respiratory problems are particularly at risk. But this virus really likes, it hooks on to lung material very easy. So hence the problem that has happened with so many with respiratory issues. And if it gets bad enough, you end up, your body tries to fight it by forming a bunch of mucus, and the mucus then can make it hard to breathe, and that cycle starts and it can be very difficult.
Yeah, this is a respiratory disease. Individuals that come in may have some gastrointestinal. In fact, we've had one that started out with nausea and some diarrhea, but quickly turned with some respiratory symptoms. But again, the reminder, as Scott had said, that touching something, touching your mouth, touching your eyes, that's the way it in general gets in. Most of the infections that have occurred have been within families passing around, which is completely understandable. But it's that hand, so washing your hands, not touching your face is really important.
So Bill, I'll ask you a question. I've noticed that the symptoms that we've seen, the symptomology, heard of people losing their taste, people losing their ability to smell, diarrhea, achy joints. It seems like there's a lot of symptoms that make it kind of difficult to figure out what's going on with this.
It really is, from a standpoint of the common flu or even having a cold. I was, at Scott's point, you can get lots of symptoms, and that's what's been difficult for physicians. Our infectious disease doctor, Dr. Rodnasamy, has just been working tirelessly on this, presented cases to the medical staff, and there were just a lot of different ways that people were presenting. It's basically respiratory, but you can get other symptoms, aching in your body, the questions that we ask, certainly having a temperature, usually a dry cough, but there can be other symptoms. And that, again, that's what has made it really difficult, because just another thing that people could have that fit into a symptomatology of another virus. read somewhere, maybe you got a cold. Well, what should you do? Wait a couple days. If you still just have cold symptoms, you probably don't have COVID. You don't need to be tested, but it is difficult to differentiate.
Dana from Finley is asking us, and this I think is probably the $64,000 question. So Dana, you might win the award here for the question of the day. When do you estimate that Hancock County and Finley will reach the peak of the COVID-19 curve?
You want to guess first?
No, sir.
Well, we've got mathematical models, and these things have been done empirically. By that, I mean they've gone back, and the British did the one that we're using back in 2008 and looked at the things that I talked about. How well did we socially isolate? How well did we self-quarantine? How soon did we get the schools closed? What did we do with the nursing homes, et cetera? And putting all these into a mathematical model where we are, and I looked at it today, that we expect in Ohio to be sometime in April. I think what's come out from the governor's office, and again, they're using a model, they're putting in data every day and see how many cases do we have, what does that predict? That what I saw today, April 19th, is a number somewhere to May the 4th. So we expect within the next 2 weeks to start to see some kind of a surge. Now, that is Ohio. How much that's going to be us, I think, is dependent upon a little bit how we've taken care of ourselves. So maybe a little bit later, or maybe we won't see that much of a curve.
One other tidbit about all this, these predictive models are pretty interesting. And to touch on a question that got asked earlier about testing, had we been able to test populations, we would have a much better ability to answer the question. But here's the other thing, is as you flatten the curve, that's the good news. Not so many people get sick all at once. If there's bad news, it also extends the time period that the virus is active. So, Bill, I don't know what you've seen. The latest model I saw had up to 180 days.
Yeah.
Last time I checked, 180 days is about 6 months, and that sounded like a long time.
Yeah, we're supposed to be pretty upbeat, but that is the mathematical model that theoretically, if we didn't
That's college football season. I didn't like that.
If we didn't do anything, if nobody would have done anything, that in general, 100% of us would have gotten the disease. That's just what would have happened. So with all of what we're doing, the model would say we're flattening the curve, but we did move it out. And part of that, why that's important, that at least from a healthcare standpoint and trying to take care of you, we will have the resources, let's say the number of ICU beds, ventilators, or whatever we need to be able to prolong it, that we'll be able to take care of you, even though it's a little longer. 180 days is certainly something that could happen. It looks like, too, that if you go back to, if there's people immune, so the people that got it early are immune, so the virus can't replicate in them, it will tend to die out. The numbers I've seen, that probably 60% of us are going to get it. Now, there may be a lot of you have already got it, don't even know you had it. So I don't want to say that to make it sound bad, but we think, one, it'll flatten the curve. That means it's not as high. We'll prolong it, but not as many of you will get it. Us will get it.
Well, and I think long-term, if we want to be positive, which I think there's reason to be here, long-term, two things. One is there's no doubt we will develop some medications that are effective.
Right.
And even more importantly, there's no doubt we will have a vaccine. So I suspect this will be a virus that doctors will begin testing for going forward, but we're going to have an arsenal at some point.
Yeah, that's a great point. The vaccine, when you read about it, you go out and check, it's talking about 12 to 18 months. But as I said, there is more research being done on this. I don't know how much it'll have to be proven to be effective, or what the FDA from our standpoint, but the sooner we can get that out and get it to people, obviously the better.
Well, this next question is one that we've kind of touched on. It's from Jennifer in Finley. With so many medical buildings on the BVH campus, are you planning on repurposing those buildings for non-COVID cases? What about dorm rooms or local hotels? The point about putting patients that don't have COVID someplace, I guess we would call it clean.
Yeah, and one of the things you have to remember is we're still taking care of routine things, or maybe they're not routine, but people are still having heart attacks, people are still having strokes. So we're dealing with those population, and we don't want to intermix them. So one of the things, as Scott said, we're going to say clean, dirty, clean being you're not COVID. And so how do we segregate those? And we have looked at different places using our facilities as to how we're going to take care of that.
Yeah, the good news is we have some options. So depending on how this so-called surge happens, we've got some really great planners that have put together specific ways that we will do just that. So thanks for the question. Nancy from Bluffton is asking us, if a patient needs to be transferred to another hospital, how would the transport be handled?
Well, that's really a pretty good question. Part of what we've been talking about in the last couple of days is regional planning. If we ran out of beds or don't have enough resources, or likewise if Toledo doesn't, Toledo's been approached by Detroit, whatever happens. So if you were going to be transported, you're going to be right now, it would be by ambulance, which means full protective gear, and there would have to be decontamination of the ambulance. So our hope is to be able to keep people here. There really isn't anything with COVID that we can't take care of unless we ran out of capacity. But you would be transported by ambulance, assuming that you're sick enough to have to go someplace else. So problems could be with a major trauma that we would need to transport, or a sick mother with a baby, or things like that. But in general, we're going to take care of things here.
And in those cases, we have helicopters.
Correct.
So Jennifer from Finley's asking, how will Blanchard Valley Hospital take care of pregnant patients during the next month? Although I think it's actually a longer time period than that potentially. If there's a surge, will a support person be allowed in the room with the laboring mothers? Will pregnant mothers be turned away from the hospital during a worst case scenario? First of all, Jennifer, you used up 3 questions in 1 question, so that was a good job. Proud of you. Go ahead, Bill.
Well, first, we're not going to turn any expected mother away. We are in the process of developing I'm going to say a safe harbor for mothers to not be exposed. Part of what we have expanded the hospital to do to have what's called negative air pressure rooms, so that the air does not circulate through. And we're trying to keep that out as much as we can. And we've been able to so far, because we haven't had a surge or an influx of obstetrical rooms where a mother can deliver. Now, obviously, we have to figure out the logistics of getting the mother to there. We will be able to take care of them. We do have some plans if there would be a tremendous surge of where we might go to a different place as far as delivering. We've talked about that, and I'm not going to get into the specifics, but we will be able to take care of pregnant mothers. We'll be able to take care of the babies, and I think that they're going to be safe. We will still have our pediatric hospitalists, and our obstetricians have worked out a call schedule, so there will be somebody available. So I don't think we're going to have any problem.
Let's stop. Ladies, any additional questions or comments have come in?
Yeah, I thought there was a really good question asking about what a patient could expect if they were to call the call center. So if you could take them through the process of calling the call center, testing, treatment, et cetera, what could they expect?
You want to take that one, Bill?
Sure.
Because I can't.
Well, I stopped down and talked to the ladies. First, we're doing it 24/7. We're not getting a lot of calls at night, but we did get one at 4 a.m. this morning that someone was having chest pain. And at that time, that individual was sent to the emergency room.
I think we've had well over 1,000 calls, right?
I think we're up 1,500. Yeah, we've had a lot of calls.
I really appreciate people using the service.
And so the call, and one of the things is I didn't know this, we have 15 counties. So it's been well outside of our service area. I know I was told we had someone drive down from Toledo that wanted to be seen. But basically, to answer the question, you would be screened with some questions. We're looking for fatigue. Do you have a cough? We're especially looking for temperature. And what other kinds of symptoms? Now, it was important before the exposure. That was a question. Have you been out of the United States? Especially, have you been in China or have you been in Italy? But as now we know it's in the community, that's not as important. We have registered nurses that are taking those calls, listening to the symptomatology. And if it sounds like this is someone that would meet the criteria for being screened, an appointment is made in what we're calling Tent City, which is right outside of the hospital on the north end, where you have a scheduled appointment. You would come in. So if it's 2:00 in the afternoon, you would be seen by a provider and listened to and decided of whether this is someone that needs to be screened. Now, again, I'm going to go back. I want to repeat is if we had plenty of testing, we would test probably any of those people. We have to look at the criteria, follow the guidelines, and then, as I said, we've done 170 or so of those. If you don't appear to have COVID or meet the criteria, you still could have another problem. And one of the things that we're developing now is a clinic that's probably going to stay where it is, where we'll treat you. If you've got a sinus infection or if you've got some other kind of problem, we may start you on medication or say you've got some other that needs to be evaluated. You could go to the emergency room or you could be referred back to your primary care doctor.
And I don't know that this has happened yet, but I did talk to one of the physicians who was staffing there. They had one patient that they were pretty concerned about. And had it been bad enough, we would have figured out how to get them admitted from right there. But, you know, you got all the challenges of someone in a car and figuring all that out. But we have really competent people there. So we'll do what we need to do depending on the situation. Nancy from Bluffton asks, is VVHS equipped to handle coronavirus patients, or will those that need hospitalization be transferred to another hospital? We've touched on that, but
yeah, I think so. And I think we really do have the capabilities and the staff, the resources. When I say that, we have the protective devices that both people need that don't feel uncomfortable at all. It's really amazing. Being an old guy, I've lived through some of these epidemics. Nothing like this. The HIV was a real scare, a scare for frontline. As a doctor, you didn't know what you might see. Our people have been really good. When Scott and I both make rounds, talking to the people, we've got positives in here. Everybody knows what they're supposed to do. They're putting on their protective gear appropriately, so they don't want to catch it themselves. Obviously, they don't want to get something and give it to somebody else, and to really take care of the patient. So I feel really pretty comfortable. We've got some really good intensivists and hospitalists too. They know how to put somebody on a ventilator, how to manage the ventilator. So I don't see that as a problem.
I don't either. And I know we're not here really to talk about Blanchard Valley, but the attitude, the spirit of the staff here is really remarkable. And so I would like to shout out to the troops here because they do a fabulous job. And I can't tell you how many times I've heard people say, hey, Scott, don't worry, we got this. Or Scott, this is what I went to school for. Or Scott, yeah, I know there's risk, but that's part of the deal. And don't worry, we will take care of our patients and we will get through this. And for someone like me who's not clinical, I'm just really proud to be able to be a part of the group.
Yeah, and I think along the same lines, we've had a team, what we call incident command, that have just been, I mean, they literally have been here every day, 16-hour days. And I know they go home and they worry about what's going on, is to try to make sure we do have the resources of what we're going to be able to do, and working with the frontline staff. I'm really proud of everybody too.
Nancy from Bluffton is asking, how many respirator and intubation machines are currently available at Blanchard Valley?
Well, we know we have at least 25 ventilators. We are also looking at anesthesia.
You probably don't know this, but we got another one today. It's a long story, but we now have 26.
I'm not sure I want to know the long story. Okay, we have 26. We are also looking at anesthesia machines. We also have 30 ventilators that are one-time use. They were designed for disasters. The other thing we're looking at is, can we use a ventilator for 2 patients if we were to need it? So there's a lot of ingenuity thinking about what we need to do. We're in unprecedented times, and so we're thinking about innovation and things that can occur. But we think right now we're pretty good supply, especially if you looked at the size of our hospital, size of our community, the number of respirators or ventilators we've got. I feel pretty comfortable.
Good. Arthur from Toledo is asking, what steps are you taking? It's a great question, to protect the people who work here.
Well, one of the things that we've done is we've wanted to make sure that everybody has been trained really well about how to use protective devices, PPE, and we've tried to follow the CDC guidelines. We've also sent a lot of our associates are working from home. Again, the key things to this are social distancing, making sure you wash your hands. And so if you can work at home, we've made attempts to do that. And that was logistically a little more difficult than what you might think. We had to have laptops, computers that could be connected.
Phones reprogrammed.
Yeah, all kinds of stuff. So, but we have worked hard on that to make sure that people are as safe as we can. Now, one of the things that has developed with time, and maybe this is a good time to talk about masks, Scott, is the whole idea of protective devices and symbolically, if nothing else, about masks. We followed CDC guidelines. And so, but there have been lots of questions about that as, can I wear a mask? Should I wear a mask? And Scott, you can tell us about your own mask.
Well, this happens to be a beautiful green and white Fighting Spartans from Michigan State, go green, go white. Bill happens to have one next to him that's a Buckeye one. The colors aren't near as good, but he's got one. And I think he makes a great point. You wear a mask, it's hard to put your hands in your mouth and your nose, and it has to filter out something. So
yeah, I mean, where we started was with, if you go read the CDC 2 or 3 weeks ago, and again, you've got to put this in the context. We did not have enough protective devices. Therefore, we want to make sure we use them for the most important places where you could get an infection. That could be a healthcare worker, somebody with a cough. And so we did not distribute those to everyone. But as we've looked into it, as Scott said, the mask may be most beneficial. If I have this mask on, I'm not as likely to touch my face, to take those droplets, to put it in my nose or in my mouth where I'm going to get an infection. So we have said to our associates that we are fine with you using cloth masks. Mine is in its container. They should be taken care of.
it's not looking that good. I just want to say.
Yeah, well, you're biased. And you want to take good care of this because you don't want to be touching it. One of the things you worry about is if everybody wears a mask, well, they think they're safe, then they start touching things. That's not good either. The other things that we've done for protection of our associates, we're taking temperature of everybody that comes in the hospital. You cannot get into the hospital without being asked questions and having your temperature taken. And we are really strict about trying social isolation or social distancing, the 6 feet. We sit in meetings and we are apart. And likewise, we make sure everybody washes their hands. We put plenty of sanitizer. We want to make sure that everybody is healthy as we can.
Thank you. Next question, and it's one of my favorites. It's Lori from Ottawa, so thank you. How can community members help during this time? Well, I think, here's what I'd say. It has been beyond gratifying the way people all over the country have reached out to their hospitals to help. I'll tell a quick story about my 94 or 93-year-old mother. She has spent the last 2 weeks where she lives working with a group of other people, and she makes sure I know that they're 6 feet apart, making masks for their local hospital. That is fabulous. So we're welcome. If you have sewn fabric masks, that's great. If you have N95 respirators, that's fabulous. Surgical masks, protective glasses, goggles, face shields, thermometers, hand sanitizer. If you'd like to make a donation, please contact a woman named Marie Swaysgood. Marie's number is 419-348-2118. I know she would be more than happy to talk to you, but we are so appreciative of what's happened in our community, and I'm safe in saying all over the United States. Americans are phenomenal givers, and this is just another example of it. Melina from Finley is asking, is nursing staff able to use personal masks for added safety?
And I think when this question came in a couple days ago, might have had a little bit different answer. As I said, yes, nurses are able to use that if they feel comfortable. We have not, now, a patient that would have symptoms, we will be putting a mask on also. I am not advising everyone out there to wear a mask. I think we already talked about how people can get it, but if you feel better wearing a bandana or wearing a mask or there's all kinds of creative things out there on how you can make a mask, that's probably okay. Specifically about a nurse, yes, they can, but we also, if they have a patient that is a PUI or a positive, they need to be in full protective gear. And it's not just a cloth mask. That would be an N95. And we are really advising with an N95 to put a mask over the top of that to keep droplets and things from coming the other way. We're still worried about protective gear.
So Bill, Arthur from Toledo is also asking, what's your opinion on cleaning masks and other PPE?
Well, that's a really good question too. You probably saw in the newspaper that Battelle in Columbus has come up with a way of my understanding of using hydrogen peroxide at a high pressure to clean N95 masks.
Sterilized, basically.
To basically sterilize, yes. The problem is it's fairly expensive, and it also is for the same person. These things are fit, so the logistics of transporting something to Battelle is something we're looking at, and it may be something that we do. There's also individuals looking about, can we use UV light? Will that be of help? Can somebody wear it for a day instead of changing it after each person? And then the other thing is we're hoping that we're going to be able to get a better supply that we'll be able to use new ones. But we are looking at all different ways of how we can reuse these.
It's another example where around the country, as the threat of us not having enough PPE was out there, people get creative. What this company called Battelle did, it has been very quickly approved by the FDA. There's also been efforts made to use ultraviolet light. And I think there's an FDA approval coming on that too, which may be another solution. So
right.
America's creative for sure. Ladies, we're getting near the end of our hour. Any more questions coming your way that we want to touch on?
Yeah, there was a couple questions regarding advice that you would have for cancer patients who have a fear of continuing treatment.
That's a great question. I'm going to let, obviously, Dr. Kose.
So I think maybe the gist of the question, there may be two parts. I'll answer it that way. One is we are continuing to be able to treat. I don't know how far the cancer care center is. Let's say our oncologists that are treating, we're reaching out by phone, we're reaching out by telehealth if we can. We obviously want to continue chemotherapy or what needs to be done. And
radiation therapy too.
Radiation therapy. We are still in the process of being able to do that. And I think we have worked those things out. The other part is, though, the protection of the person that has cancer would be one with your immune system is probably not as good as what it would normally be. So that person needs to be more careful, probably even self-quarantine them more than what they normally would. But again, we're available to help and to take care of them.
It's a great question. Anything else?
Not that you haven't already covered, just a lot of really great feedback.
Mindy, anything? Okay. Well, one final question, and this is, again, another gratifying one. We've been asked by many people in the community, is there a place I can donate money to help? And that's just really a nice offer. So we do have an emergency response fund that's been established here. If you'd like to consider that or think that's something you'd like to do, back to Marie again. Marie Swaysgood is the person to contact. Her number is 419-348-2118. So for anyone that's interested in that, that's fantastic. We're just about at an hour, and I'm going to close by, again, thanking you for being here. Thank you, Dr. Kose. Hopefully, we achieved our goal. We tried to provide some information. We tried to answer some questions. We're going to have a Survey Monkey available. The question is this: is this valuable? We did this to try and, in a very simple way, provide information to people. we can do another one of these if it's useful. If it's not, let us know. So we'd really appreciate the feedback. If you have additional questions, we will, I think we're already making you aware of how to do that. This is all about information. No doubt about it. The more you know about this, the less there is to be afraid of. And so that's our goal here. We've enjoyed being with you. We're happy to do it again, as I just said. Bill, anything, final comments?
No, social distance, don't touch your face, the usual. And I echo what Scott said. This is a great community. Thanks to everybody for what you've done. And we really do appreciate the feedback we've gotten for all of our frontline staff and how appreciative you are.
So from a Buckeye and a Spartan, thanks for being with us, and take care, everyone.